Healthcare costs in the US are completely unsustainable. I don't know where we go from here, but yeah, I am terrified that that actually destroys like people's lives.
Good morning, everybody. Today, I'm super excited for this conversation with Elina of Ilant Health, and we're going to get into a whole bunch of things around health tech, around what your particular founder journey has been like, and all that jazz. But before we get into questions that are going to be a little bit more unstructured and all over the place and kind of pathwindy, let's start with this. Give everybody the context. What does the company do today? What is it from a high level and a mission basis? And then we'll get all sorts of weeds going.
Perfect. So we provide value-based obesity management and cardiometabolic health, which is a mouthful. So let's break that down. Value-based actually means that we try to provide care that does right by the member, but also does right by the system. And what I mean by that is healthcare costs in the US are completely unsustainable. And so what we're trying to do is not just add to that problem, but actually reduce the total cost of care. And actually, obesity treatment's an incredible opportunity to do that, because obesity causes about 200 other conditions, right? So things that we may say like, oh, that makes sense, like diabetes or hypertension or musculoskeletal pain, but also associated with depression and anxiety, associated with infertility, associated with 13 cancers. And so there's a whole host of costs that come from treatment. Unfortunately, a lot of times the people who need treatment the most don't get it. And so our real and why, and hopefully we'll dig into this later, is stigma and shame and a lot of things that we saw in mental health earlier. So our real focus is how do we actually use obesity treatment to reduce diabetes, to reduce, knee replacements, to reduce infertility, to reduce cancers, to reduce, disabilities and workers' comp costs, to increase productivity, and then, drive value for individuals because our obesity treatment literally extends life. So I know longevity is super popular and people are like, let's drink whatever is the current probiotic, et cetera. But obesity treatment actually extends longevity for people who really need it and also save, money in the system. And so I think that's a lot of what we do. And how do we do it? We combine analytics, a really high quality care team, and technology. So our analytics are proprietary. They're focused on actually identifying who are the individuals who will benefit from treatment the most and also matching them to the right treatment. I'm sure all of you have heard of either Ozempic or GLPs. If you haven't, please get out from whatever multiple rocks you're under. But that it's been touted as a miracle cure. It's an incredible, incredible medication. It's not a miracle. And there's, better treatments for some people. And so we actually really focus on matching individuals to that treatment and then actually driving outcomes for them, right? So I've been in healthcare for decades. It's very, very rare to have, a treatment without a care team, without support, actually drive value. And so a lot of our focus is also what's the wraparound that we have around the individual and the treatment to help them be successful. And so, it's a really deep pairing of analytics, of human touch, and then the technology that sort of enables us to deliver that.
So it's really interesting. I want to actually dive into the stigma a little bit early, but in a certain way, which gets to also the GLP drugs, class of drugs. So let me start by asking you a question about not your company.
Okay.
So in this kind of like acute treatment area, look, I'll just name the startups that I'm curious to hear your opinion about. It's like
we're going there already? It's been like 30 seconds.
We're going to dive right in.
Okay.
Cerebral, Done, Roman, which like for a lot of folks in the startup industry, we've kind of looked and gone, they seem to have built an easy pathway to drugs. You're particularly not doing that. And I want to get into that because one of the first things I noticed when I wanted to, prepare for this conversation is like your latest LinkedIn post says something like, not the same treatment for everybody. You're like making that point about, for example, the GLP-1 drugs. And I think that's fantastic. It's like, hey, there's a whole set of things here, and this is one potential option for you. Whereas there are a lot of startups and a lot of venture-backed startups who have approached this and said, hey, whispering certain words at us will get you, for example, an Adderall prescription.
You don't even need to whisper those words.
Exactly.
Just,
show up.
Show up.
Yeah.
Have a credit card.
And
have a pulse.
Some of them seem to finally be getting hit with regulation, but some haven't. And then some of them have approached having Ozempic or Mounjaro or whatever as part of, now they're pivoting to, hey, we'll offer you, ED pills and also weight loss drugs or weight loss enabling drugs. which may or may not be valid as an approach. What's your thought, though, on like, let's call them the more generic players in the space? They're not taking a, hey, we want to treat obesity or want to treat diabetes or want to treat ADHD holistically. They're taking a, hey, we want to be an easier pathway to a telemedicine and prescription delivery mechanism. Or I might be putting a lot of bias and loaded language there. What's your take?
So I have so many thoughts, so cut me off at like the 5-minute mark. Just kidding, 2 minutes max. So look, I think this is sort of a good idea gone really, really bad. And I think it stems from a combination of sort of systemic issues in many cases in venture-backed businesses. So let me start with the good idea or insight. Access in healthcare is really terrible on like every dimension, right? Like, I don't know how many, when you guys go to a doctor visit, I personally show up 30 minutes early because Lord knows, despite the fact that I've been going to that doctor for years, they're going to have the same forms and you have to fill them out. Like, don't argue, just fill them out. It will be, I promise, it'll be shorter. So you show up 30 minutes early. Take the earliest appointment because they're least likely to be running late, but they're probably still running late. And then I book 2 hours after the appointment on my calendar without meetings because I assume that something will go wrong and they're running late.
That's your buffer time.
Yeah, like that's like it's now how I treat airline flights as well. Like when I fly now, I like book the half day after the flight with no meetings because I just assume like something will go wrong. And like, that's not functional, right? It's super not functional. A lot of times those and by the way, it's no one's fault in some sense, right? Like the systems aren't well set up. The doctors are double booked because the patients don't show up. Like there's a lot, like, it's not like, it is like Dr. Joe's fault or, Mount Sinai's fault or whoever it is. There's a lot of problems in the system. And I think on top of that, the bias absolutely exists in the system. And so people who are not considered sort of normal in whatever way are not treated well. And so I think a lot of these startups started with a good insight, which is that we have real access issues and that sort of the experience can be better. Then I think things went wrong. So I think what we're looking for in the system is consumer orientation. Consumer orientation doesn't mean giving people what they want in the minute they want it, because honestly, if it did, we don't need doctors. Like, why have doctors? Why don't we all just like show up to a store and like buy the procedure we want?
Some people would like that to be how our system works.
Maybe. I think people would like that in the first like minute.
Week, yeah.
And then they'd be like, holy moly, like no one told me this was going to happen. And you're like, you said you didn't want to know, right? Like, and so, and by the way, that to me is like some of what's happening with GLPs, which is people are like, oh my God, so many people are quitting. And I'm like, yeah, they got prescribed basically by a computer and like TikTok. And like TikTok's actually not a doctor. I don't know if anyone, like shocking, I know. These are the types of incredible insights we bring every day. So I think people said like, look, the system isn't working. But instead of saying like, hey, how do you actually take the things that are still important in healthcare, which is really high quality care, which is trust between a provider and a member or a patient, and how do you make them better? They sort of went this direct to consumer route. And look, I do sort of blame the funding mechanisms a little bit behind that because direct to consumer's fast, right? You sort of put up a shingle, you get your first couple members, and then I think what people also miss is, and this is why we actually never went direct to consumer. The people who come in the door initially don't actually look like the people you want to get 2 months later, 5 months later, 2 years later. And so I think what happened in a lot of these startups is they started with a good intent, which is let's increase access, let's make the system better. But then that got perverted in some sense by one, a lack of understanding of the system. So if you look at the individuals at those companies you named, very few of them came from healthcare. And then I also think there's just this really big focus on exponential revenue growth without then like, hey, is there quality attached to it? Are there sort of outcomes attached to it? And so, the example I give even in value-based care, so I talked to you about value-based care saving money. Well, when you sign a value-based care contract appropriately, what you say is before we ever discuss saving money, the outcome and quality metrics better not have gone down,
Right.
and they should have gone up. And so I think it's those types of controls that sort of didn't get put in place because sort of the number one goal was growth. And so it really took a concept that was, I think well-intentioned at some point in time and really got it wrong.
So, I want to get to value-based care a little bit, but let's stick on that on the concept of what will happen with the GLP-1 drugs. Startups are going to take advantage of this. It was interesting to see, like, the industry was the first, I feel like, early adopter alongside Hollywood. The individuals within it started to take Ozempic as, like, I remember when it first started to get talked about within tech circles. My sister is a physician scientist who works on diabetes medicine, and literally called her and I mentioned one of the drugs. She goes, "Yeah, wait, what? We're using these to treat diabetes and acute symptoms. What are you talking about?" I go, no, I have like friends of friends in tech who are beginning to take these as weight loss drugs. What is going to stop us from making the exact same pattern of mistakes that happened with prescription amphetamines with these drugs?
I hope some level of pattern recognition,
Okay,
maybe.
that's it, though.
I hope.
I'm worried that that's like not enough. So we probably are going to go down the same path.
I hope not, but I hope not. I mean, that's in some sense, when I started Ilant, people asked me, like, what's the thing I worry about the most? And I actually think the thing I worry about the most is that the use of these medications is perverted in a way that sort of the actual system turns away from it.
Right.
And then people who actually need it don't get it because someone decided that they wanted to go from a size 2 to a size 0. And there are a lot of startups willing to sell them a drug to do that. And that then sort of caused the belief that they're risky and dangerous and reduced access. And then people who really need this, who it's going to change their lives, don't get it. And, to be honest, I see some of this already. And I see activists in this space getting really angry at health plans or at governments that are shutting down access. But you're also like, yes, but like it's not. It's very hard to control something that's out of control. And if there are, to be blunt, what I would term bad actors in the space. So I was talking to a colleague of mine at a payer in the Southeast about a year ago, and they said, Elina, like, you will not believe this. There are literally companies moving in, and all they do is basically like learn our prior auth process and then figure out how to like get around it, right? So they're not providing any clinical care. They're like, all they do is just like every time we update our prior auth process, they just go in and like basically like throw a bot at it or try to figure out like how you win. And then they just like throw as many like scripts in. And so we know that's happening, right? And so as long as that's happening, if you're sitting on the other side, what do you do? Forget even money if you're just trying to keep people safe.
Right.
Because ultimately, like, what is happening, like, we can talk about the financial impact. And by the way, I do think that's devastating because as the cost of healthcare goes up, the health equity of it goes down, right? People least able to pay more copays, least able to pay higher premiums, have less income. They tend to be Black and brown. They tend to have, harder access. And so that's a problem in and of itself. But let's even remove that problem and say, like, money grew on trees and we solved that. Actually delivering sort of a pretty high potency medication that sort of passes the blood-brain barrier to people who don't need it carries risk with it. And so, yes, I will say, like, it is one of the things I am terrified of because as someone who's lived with obesity, I know how devastating that is. And I really hope that we don't sort of destroy pathways to sort of a different life for people because XYZ sort of organization. And by the way, not all VC backed, right? The companies I told you about, that's not Roe or Hims and Hers. These are like, frankly, mom and pop shops who are like, I can make, tens of millions of dollars with like no CapEx really quickly by just gaming the system. I don't know where we go from here, but yeah, I am terrified that that actually sort of destroys not just, the industry, but actually destroys like people's lives.
It reminds me, the hijacking of process, like it's a little bit of an analogy to the Zenefits story back in the day, where like the brokers got these automated tools to pass like state certification tests that they had to take, which wound up being a whole story also about a power struggle at the company, which has, been kind of litigated now through podcasts. But interesting moment of that company was doing something really well in terms of the automation, the access it was bringing, the way it was digitizing an archaic and legacy process. And then as soon as they decided, hey, we're going to look at certain systems and processes and decide we don't care about them as much as everyone else has in this industry, that's when everything kind of broke for that company. And it sounds like something similar could happen here. Let's get to kind of the care portion of this. So mentioned TikTok earlier, and TikTok is not a doctor. I almost see companies like yours and there are a few other health tech startups that over the past few months we've had, specifically at Founders Friday, that are all around this value-based care and similar kind of like, I'd say, mission-driven founders, where it feels like it's the antithesis to what's happening on TikTok. On TikTok, it's kind of like the genericism around your symptoms, and here's what everyone who has this set of 3 very vague, broad ailments should diagnose themselves with. And that's happening just at scale through algorithms. And it seems like a lot of the startup founders that I talk to, it's like they're trying to basically pull people back in the opposite direction and go, hey, there's a personalization to your care that we're all now missing. And that was already missing before in healthcare, and now it's even worse because people are almost misdiagnosing themselves, misunderstanding their own symptoms, misunderstanding their own care. How much of this for you is a reaction to obesity historically, and how much of it is like a modern problem also caused by some of these things happening, let's say on social? Or is that small?
So yes. So I think, look, as much as I make fun of TikTok, because it's hard not to, I mean, my joke is it's like, TikTok's almost the like expansion of like this worked for my dog walker, this worked for like Uncle Mo's like hairdresser, barber's friend, cousin, sister. So I think the problem is, again, I do think people have a hard time getting access to their physicians. They often don't feel heard, right? And then they actually go out to the community, right? Which historically was friends, whatever. And then now I do think social media has created this concept that like that community exists, that you can access it more broadly. So I do think there's actually powerful lessons there around what it means for people to feel heard, right? To feel like there's sort of someone like them that they can empathize with, all of those pieces. And I will say in our care model, we actually use peer-based support under the supervision of an MD, but we actually lean into that, which is this reality that in our world, people feel judged by the people in the white coats, right? And so I do think there is this concept of democratization and being able to access information and understand things for yourself that is real there. I think the problem is that it's then applied indiscriminately and it's not actually overseen. And so I think we try to be respectful of this, frankly, need people have to feel heard, to not feel judged, to feel like there's people like them, but also that this is clinical care. There is a reason doctors go to medical school. It's not because they don't enjoy sleeping or, and yes, there's actually a lot of technology enablement, right, that I think we can do to sort of make doctors more efficient and but ultimately, like, there is clinical judgment that needs to be applied. And then I think beyond that, I think a lot of times what people miss is the human element. So like, I deeply so I think there's so much excitement right now, right, around like AI health nudges. And I think there's this like very techno-forward belief that people have that like people don't know what to do, as if like, the question is, it's Sunday afternoon and you're like, what is healthier? Day drinking or going to the gym? How many people need a technology tool to help them with that answer? Anyone feel like that is like a source of confusion for you? Okay, let me try another one. You go to a restaurant and there's a salad or the chocolate cake. Anyone feel like this is an incredible moment to get nutrition?
Cake makes me feel very healthy.
So I think there's like this very, very strong belief that people who are like very techno-forward, that like people don't know it. And like sometimes
it comes
people—
from like the habit, hijacking theory of the world,
yeah,
right?
and look, I do believe in some of the habit hijacking concept,
right.
But like—
we're taking it too far.
I think there's like this very deep— but by the way, I also use Duolingo, but sometimes I'm like, stop prompting me. I'm busy. Like, I don't care who took fifth place. So I do think there's like, and it's good, like, part of starting a startup, part of being, tech-oriented is being sort of optimistic, but I think people are sometimes missing the point, which is the problem is not that people don't know that a carrot is healthier than a piece of chocolate cake, right?
Well, I think this is especially true, not to get into the politics of this, quote unquote, but like, I'm sure, and you correct me if I'm wrong, but like you probably feel that a lot of folks, I feel this as a not health tech founder, a lot of startup folks underestimate how other people experience these problems because we come from such privileged classes, no matter what people want to say about tech being a meritocracy, which in a lot of ways it is, in a lot of ways it isn't. And so like their abilities to understand, okay, someone going through, let's say, struggling with obesity or struggling with any other sort of health diagnosis, they go, well, it's habits, or like, why don't they also watch David Goggins or something? And it's like, no, there's like a difference to someone who's living not on the coast, who doesn't come from an elite background, who doesn't have access to resources in the same way, exactly all the things you've been talking about, and the ability for that person, the person they are, to use a habit hijacking method to solve their problems. Yeah, they have that ability, and that's going to give them that marginal improvement that they're looking for in life. But someone who's set way far back and has so much more to overcome, that 10% improvement barely moves the needle.
Yeah, I mean, I think absolutely. So we focus a lot on what's often called social determinants of health, right? But not doing it judgmentally. Like, you can be healthy and not eat out of Whole Foods, right? You have to actually understand where people are coming from. By the way, what is meaningful for them and enable that. So, I look at, and by the way, I've probably done every extreme diet out there. Like, if anyone has not done the grapefruit diet, don't try, but I did that one as well, because like, I like to consider myself like a generally sane and rational person, but you're so desperate at some point in time where you're like, sure. Like, why not try just eating a grape? Like, if that works, like, sure. But I think the point is, like, you really have to understand where people are coming from, like what's going on with their families, not just income, but even like, are you sort of a mom and you have 2 teenage boys? Like, if I say to you, like, the only way to get healthy is to never eat with them again, you're going to be like, thanks for that advice. I'm going to choose not healthy and to actually know my kids. So there's a lot of complexities there, but I also think there's an element here around, it's not just income, it's also like, how do people empathize, or what makes them change? So I think a lot of folks at startups are very data driven. I love data, right? Like, there's probably like no amount of data you could give me that I wouldn't be like, oh, that's really interesting. Like, is there a deep dive? Is there a cross-cut on that? And that's great. Like, that's, that works for me. Like, right, the physicians actually I really appreciate are the ones who can be like, okay, well, Elina, this option has a probability of 70%, and this option has a probability of 50%. For many people, that's like, I don't know what you're saying, like, which option should I do? And so, like, I look at things that get really, tech people really excited, like Aura rings and Whoops. And, I have an Aura ring. I have lots of friends with these things, and they like send you like reams of reporting, like reams of data. And they're like, look, I like ran a simulator on my daily check-ins for the last year. And I realized that when I go to sleep, like 10 minutes later, like I have 3% less energy. And that's wonderful if that motivates you. Please understand that the vast majority of like the human race does not want to run a simulator on incredibly detailed data. And so, when we talk about helping people change, and this is, I think, some of the gap around like human interaction is, it's got to be meaningful for them, not for you.
So let's talk about how that turns into what you've built today from a product perspective. So, because I can feel a lot of this, and maybe let's start actually with your background, because you could very easily be like a health plan, kind of activist, trying to change how actual healthcare works using the same language. But you're not. You're a technologist building this into, a platform that I assume is parts tech-enabled services, parts digital, parts care change. But you have, to my understanding of your background, it's a mixture of consulting that turns into, kind of healthcare work, and then, kind of what now can be considered kind of the health tech version or portion of your career. Talk about, that journey to what Ilant is today? How did you go down that pathway to decide, hey, this is the approach I want to take versus staying, let's say purely within healthcare, or taking again, the mantle, as you talked about, of the more data-driven, more tech-forward approach of I'm going to become a startup founder?
Yeah, I don't know if this was aspirational or not, but like I actually had like very low aspirations to be a startup founder for this. Like I was like, man, it's like hard, right? Like it is super, super hard, right? And in many ways, like I do come from the system, and I'm actually a deep believer in impact, right? Like, so to me, it's like how do you scale impact? How do you affect people, right? And so I do think you can work at a large organization and do that. You can do a startup and do that. But the reason I landed here is I had this insight, frankly, coming out of my own journey. So a couple years ago, I sort of gave up on every diet. And, I had done Equinox, I had Peloton, I had done SoulCycle, Flywheel, Bar Method, every meal delivery you've ever thought of, every weight loss spa in the country. I'd like lived for a month in Canyon Ranch. I did the same thing at Miraval. Like, I guarantee if you have heard of the trend, I have done it. And it just wasn't working. And I am a physicist by training. So I sort of felt like I was probably pretty good at calories in, calories out. Like that does not feel like complex math. And so at some point I was like, this isn't working, right? And I gave up. I was, in my mid-30s at my highest weight. And I was like, I just cannot keep doing what I've been doing for the last 30 years, like trying every diet and exercise fad and sort of gaining weight. And sort of in a tremendous amount of shame and stigma, I went and I got bariatric surgery and I referred myself into obesity medicine. And, I was a senior executive at a health plan at that time. I could have gotten so much support, right? Like I could have gone to my CMO and said, like, who do you know who does this? No, totally did it completely under the radar, right? Like was so ashamed. And I came out of that journey and I had an aha moment. And I like to say, like all good HBS case studies, I was in Florida where my family lives. I was on the beach. I looked towards the ocean. I was like, oh my God, I've seen this movie before. This is Mental Health 10 years ago.
Oh, interesting.
And just the fact that we have a treatment that works, that there's so much shame and stigma around it, and it's not utilized properly. And then I sort of went out and said, like, does anyone else, first of all, is this insight real? Like, not that, sitting on the beach and sort of thinking something isn't but is this real? So I spent about 6 months in deep actuarial studies talking to actuaries I knew, CMOs I knew. And I actually came to realize the studies were real that I was finding that sort of led to that insight, and people didn't know in the industry. And then I was sort of like, well, what do I do about this, right? I can go and try to sort of innovate it from within a plan or within a provider, but I just didn't feel like the solutions exist. And by the way, at the time there was Calibrate, and people kept on being like, oh my God, Elina, you should start another Calibrate. And I was basically like, no, direct to consumer solutions that sell medication as a treatment, that is my kindest way of saying it, don't actually work, right? They may generate dollars in the near term, but they're actually not something that's going to work for the member, and it's certainly not going to work for health plans and employers. And so I would say the insight of why I landed here is I looked at sort of, okay, I see that there's an opportunity here. And then I see a lot of problems in reaching that opportunity, and problems around perceptions, around lack of sort of great clinical care in the existing system. And so basically landed here by trying to sort of say, how do we solve those problems? Do I see anyone doing that? No.
I guess part of that calculation for you too was after you went through, was that last portion for you, would you consider successful?
Same.
For your own journey? When you went through that treatment?
It was, yeah.
And so did you then go, but not everyone should do exactly what I did? I think that's the interesting part of the insight. You didn't then go, let me make just this more accessible. You said there's something complicated here related to, yes, the shame, yes, the conversations, but there's something else there around you not discovering the cure.
Yeah, so it's a great, so yes, the journey was successful, and I got terrible support. So I actually had side effects, there was no support for it, could not get any, and I would honestly say, I don't know that someone who didn't have my background, who wasn't actually incredibly health educated and literate and could go on Google and go find the studies that basically, okay, here's what I should be doing, who didn't actually have a family, I have family members who are clinicians who I could get help for, So yes, maybe the way to say it is the outcome for me was successful. I lost over 100 pounds sustainably for the first time in my life. I think the treatment was successful, but both my journey to the treatment and then the support I got were abysmal.
Well, so like I can guess some of the answers here, but given how big of an issue this is in the U.S., why, other than the stigma, and so that causes like the patients to not seek or get some, kind of community support, why are health plans and the system in general not incentivized as much as maybe a layperson would think from the outside, given, again, how much we hear about this, over the past, let's call it, I'd say 5 to 8 years has become such a mainstream topic. All politicians will talk about it, and, it's kind of put next to the opioid crisis and other places. Like, here are the things in America that we have to fix. Where is the lack of systemic support coming from?
Yeah, so I think lots of places. So let's start with bias. I think there is huge implicit bias against obesity. So if you want to test your own, I actually recommend the Harvard implicit bias test, which, by the way, if you want to test your bias on anything, is great. I've tried to trick it sometimes and be like, go slower on the one you're not supposed to be. And it is very hard. We all have implicit bias, right? But obesity is actually one of the last areas that it's okay to be biased on, right? Mm-hmm. And in fact, many times people will view that bias as positive, as motivational for people with obesity, right? We bias people with obesity so that we encourage them to lose weight. If any of you believe that, please, I promise you, no person with obesity is sitting around being like, should I lose weight? They're very clear they should lose weight. No bias application needed to sort of support that motivation. But I do think there was historically a belief that people, and by the way, there's studies on this, right? And by the way, that belief is held by people in the healthcare system. So physicians describe people with obesity as lazy and disgusting and unmotivated and uncompliant. And by the way, those types of words are very commonly used. I actually now still see this. So that has sort of become less okay. But now the coded words I see around that are root cause. So people will say to me we're not going to pay for treatment. I want to get to the root cause of obesity. And what they're saying is it's the habits. It's their fault. But now we just say it in a different way, root cause. And by the way, I do think we should get to the root cause of obesity, which is very complex. It includes genetics, it includes habits, it includes your mental health, it includes your food access. But I think bias is very, very entrenched. And even some of the early folks I talked to who are very data-driven would look at all the data that said people cannot lose weight sustainably. And they'd look at 20 studies and they'd still be like, but when I was a high school football player or wrestler and I needed to lose 5 pounds to make weight, I just didn't eat for the weekend and I lost
Drank
the
water.
weight. Yeah. And you're okay, that is definitely your experience. That may not be a practical option for someone who needs to lose 50 pounds, right? We just can't scale at that. You can't be okay, well, to lose 5 pounds, you didn't eat for the weekend, so should they not eat for 20 weeks, right? How does this work? And then what happens? And I'm sort of making a joke out of it because the reality is once you then start eating, you regain the weight and more, and very, very extensive studies. But I think you can look at things like Biggest Loser that basically had so much popularity because people were yes, this is the way. So bias is absolutely.
But really what you're saying there is bias that was infused and infected inside the system itself.
Bias
because it's not bias by itself.
Yeah.
Right. But I guess if we give our healthcare system some credit, or healthcare in general, not our system necessarily, doctors are probably still some of our more data-driven professionals if we just include it on a relative basis, right? They still might not be at nirvana of being data-driven, but we give them a lot of credit, and we probably should, in terms of compared to other things we do in life, in profession. But this bias is so infectious that it almost it ruined the ability of the healthcare system to help itself.
Yeah, and then it was embedded, right? So obesity is not taught in medical school, right? So it's still not taught in medical school, right? And so yes, it's sort of general bias, but then it was embedded in the system. So that's part one of the problem. Part two of the problem is that, frankly, there was a perception that the impact of obesity is really far out, right? So people would say sure, if a 30-year-old loses a bunch of weight, they don't, get diabetes when they're 60 and they don't cost Medicare a ton of money. But that, other than altruism, right? Like that doesn't help my bottom line. And so, by the way, that's actually one of the misperceptions we attack really significantly. That's part of the analytics we've built. We call it Ilant Rapid Returns. We basically identify who are the individuals where there is very near-term savings, right? And I think one of the things that has happened is like we have chronic kidney disease in 30 and 40-year-olds now, right? We have diabetes much earlier. We have all these things, right? And so I do think like part of that is actually demonstrating for folks that, hey, it's not just that you're saving Medicare money, right? This is not just like do good in the world. This is actually help your bottom line. And then, look, I think there had to be an enabler for that, which is effective treatment. And I think GLPs are a component of that. I also really believe bariatric surgery is a component of that. And at the same time that sort of GLPs were being created, laparoscopic approaches for bariatric surgery are also coming in place. So now we and by the way, not just GLPs, we also have other medications that came a little earlier, Kisimia, Contrave, other sort of non-GLP anti-obesity medications. So I think you have a confluence of factors, which is you have bias, and in general, we've sort of been trying to address bias, but you also, I think, historically had this view that like, okay, the costs are not mine, so I'll sort of put a couple dollars against it, but this is like my do-good deed of the day, as opposed to, hey, a way to save money in the system and improve health is actually to treat obesity. And then the third is we actually needed a way to do it. And so I think we had gaps in all three of those areas that are now sort of coming together. And the one we really try to attack is actually that second one, which is really increasing the understanding of cost and clinical impact. Because a lot of times, if physicians sort of and others in the system don't love the idea that like, oh, we're solving for cost. And I'm like, this isn't like random cost. This isn't like someone sprinkled dollars. Like the costs exist because someone has diabetes and they have to go to a specialist all the time and they have to get meds, or someone has a musculoskeletal issue and they're getting corticosteroid shots, or they have to go to a knee replacement. And so, I actually deeply, but like cost is a reflection of someone engaging with the system more in very high cost in non-great ways, right? They fell off the sidewalk and now they need to go to the hospital and it's hard to operate. So, but I do think making those connections had been missing. And that's a lot of what we're trying to also address, is helping people see those connections and then say, okay, wait a second, I could reduce all these other cost centers if I address this issue.
Two more questions from me before I go to the crowd, because I've taken so much of the time on hearing your thematic answers, but to get practical on two things. One is, who's the primary business model being delivered to? Are you convincing large-scale employers about this, so they can implement their health solutions for their employees? Is this health plans themselves, insurers? How are you delivering Ilant Health at a high level?
Both. So we basically sell to whoever's paying.
Okay.
Right? And by the way, why do I believe this is really important? Because that's the way you actually access most Americans. So I think one of the things that people get wrong is oftentimes business models in this space are started by selling to people who can afford things, right? And there's actually a very small number of those people, but they're easy to access, right? It's like I have, my friends know I'm very passionate about saving money in healthcare. And every once in a while, they'll be like, Elina, you'll be so proud. And I'm like, oh boy, here we go. They're like, I just spent $2,000 on testing that showed me that I have, inflammation from figs. And now I'm going to save so much money. And my question is usually, but I no longer ask these because it's not appreciated, is like, how many figs were you eating beforehand? And like, was this like a huge, like that $2,000 to discover that figs like are not great for you may not be like a great, return on investment. But like we all live in communities where people are like, yes, like I want to spend $2,000 to find out that like I shouldn't eat figs. That exists, right? But the reality is for the vast majority of Americans, they can't afford they can barely afford their premiums and their copays, much less extra testing. So very deeply believe the only way to get this to work, and the only way to get access to, frankly, the 100 million plus Americans with obesity, that's over 50% of the U.S. population, is to get it through the people paying. And people paying are employers and health plans. And to get it to employers and health plans, you have to drive a multitude of values. So you have to drive experience, because otherwise people won't engage. And any program that people won't do doesn't work. 2, you actually have to drive clinical outcomes. And 3, you have to do it in a financially viable way. So we sell to both, and we've seen actually great success in both. So I think some of the largest employers love our model. We're also actually seeing health plans interested in it for their fully insured books. And I think one of the things that's important to me, because I do believe in equity, is we do access commercial fully insured with health plans, but we're also focused on Medicaid and Medicare, right? And I cannot say this more strongly, you cannot say that you're going to address obesity if you do not address it for people who are lower income, because obesity is a health equity issue. It is more prevalent if you have low income, if you have lower education, if you're Black and brown, or if you live in rural settings. So you cannot address obesity. Any startup you see who's like, we're going to cure obesity by selling stuff to people in large metropolitan centers, like, false, right? Like, that's not where a lot of obesity is. So that's sort of our model. And the way our model works is that we provide everything in sort of one capitated rate. So we take on risk and we have upside and downside. And when I say everything, that includes, for those who are interested in, it's largely health plans, the analytics that say who will really benefit from treatment. And one of the really interesting insights we've seen, because we've been running analytics, is there's a lot of what I call adverse selection in the market right now, and we expected this. Adverse selection is actually very normal in highly stigmatized areas. So what does that mean? It means that oftentimes the people who don't need treatment are getting treatment, and the people who do need treatment are not. And we can literally see it in the data. And why is that happening? It's happening for all the bias and stigma out there, right? So by the way, this also happened in mental health. Earliest mental health treatment often ended up with low-grade depression and anxiety, not with serious mental illness, right? Why? Because stigma is often proportionate to the level of disease. And so the more stigma you have, the less likely you are to engage. We think it's really important to identify the people you really want to engage and be there for them.
So this is like people who are at risk for obesity were receiving, almost
have really high obesity levels. So we treat right now from 27 BMI to 80 BMI. Over 10% of our population is over 50 BMI.
And so when you're going and you're finding these analytics, then they're offering your care program to people that you've identified, or does it work differently? How does it go from?
So it depends. Yeah. So with the health plans, because they do want to proactively target individuals who need it, it will be sort of proactively target those folks we've identified. In employers, we're often offering it broadly to everyone. But I think one of the things that's really important to us is even when we broadly offer, we tend to engage people who are higher acuity. And I believe we do that for a couple of reasons. One, we're not pushing a pill or a solution. We're actually sort of saying like, hey, come to us and get help. And 2, we're super non-judgmental, right? So we're like, a lot of us in the company have lived experience. We're really focused on the language we use. I'll do an aside. Our first designer who sort of created graphics for us, the first graph, I can only describe them as bowling balls with arms and legs. And I was like, what is this? And he was like, I was trying to draw people with obesity. And I was like, do you think anyone would like to feel that this is them? Like anyone? Like, and he was like, well, I've never drawn people with obesity before. And I was like, anything but this, right?
Did that designer work out?
It did. I mean, actually, he's a great guy and there's a lot of coaching. But like, I was literally like, who would make do you want to feel like a bowling ball? Have you seen any bowling balls around? And so that's really important, but it's like we embed that in our organization as well. Like the first person you access on our team, we call them a peer navigator. This is someone with lived obesity experience, and they're not clinical. They're basically that friend, right, who's going to engage you, who's going to sort of build trust with you.
And I'm curious, that person and then the rest of the care team, are those your staff? Are those network staff? So all your staff? They're
all our staff, and I think that is let's just call it that is more expensive. It also embeds high quality care, right?
Which, by the way, we've had a lot of health tech founders at Founders Friday over the past few months. So I'm overexposed to a lot of this right now. It feels everyone is making that choice, which is interesting and notable because, to your point, it's so expensive, requires a lot more capital investment, requires a lot more risk, to your point, upside and downside in every kind of case file that you guys take on. But it feels like every one of these founders, especially folks who have healthcare experience like you do, some of them even were medical doctors themselves, it feels like it's table stakes at this point, because otherwise you're outsourcing too much of not the value-based care portion, but like the values of the person, the approach of a lot of these new methods of holistic care is not probably the right term here, but like the holistic approach to the person requires that each person is considering who's the other provider down the chain, what's the continuity of care over time, and to outsource it just seems unfeasible at this point almost. Is that, how hard was that choice?
So to me, it wasn't a hard choice because I wasn't trying to like build the, like the fastest growing.
But, let's give it a charitable though alternative. It could have been you going, I couldn't scale this business as much if it was only, that could have been the other thought in your head, right? Is like, it's so hard if I have to staff all of this.
So I think that's a false trade-off. I think the reality is if you are focused on quality and if you, like, I don't understand, this seems to me to be a logical, incongruity. If you say that your care model is differentiated, but you don't employ the people, like how could your care model ever be differentiated? Like how would people ever invest enough time and effort in coordination and understanding your processes if you don't employ them? So
is it hard to employ them? I guess like the approach would be to say something like, to not go more fractional in nature would mean that you are going to run across healthcare staffing issues.
Yeah, so I would say the hardest part is actually, and this is a system issue, like so it's not hard. By the way, physicians would prefer to be employed actually like work, especially in a model like ours. Like physicians love our model because like we've actually gotten the right care team in place, right? Where we had a physician on our staff who was getting a personal training. Like she'd already gotten her nutrition license and I was like, why? And she was like, well, my patients need all this support. And like, I didn't feel qualified. So I went and I got this license. Like that's a terrible use of her time, right? So physicians actually love our model. They love that they have all this, our patients have the support they need without them having to do all of it. The thing that's hard about it is actually the like cross-state licensing. So what I mean by that is, it's not hard to scale and fill capacity if like you could basically say any qualified physician could go to any state. The biggest issue for us is there is real cost in sort of getting someone licensed in additional states, credentialed with additional health plans. And therefore you have to be really good at predicting your demand and where it's like, that's the challenge. That's, I think, the piece that like fractional sort of headcount solves for, because you can be like, oh man, like way more demand in Idaho than I ever imagined. Like, let's go quickly find fractional talent. And I think that's okay, right? And like you have to, that's a consideration. But I think the piece to understand is like, you've got to deliver quality, right? Like, I think this is a really big miss that people have, especially in healthcare. The hard part is not getting someone to walk it. Like, I think too much of healthcare has been using the gym model. And what I mean by the gym model is like December and January, someone sells you really hard, right? Really hard. And you sign up for an annual plan. And then they just don't care if you don't show. And then like around November, December, they're trying to re-engage you so you don't quit. But like if you showed up February through like October, that's your issue, right? I think there's so much focus on getting people in the door, but that's not where value's created. Not for the individual, not for the system. Value's created in February, March, April, May. Like it's created on engaging people on an ongoing basis.
And so is this like, if I hear what you're saying there, really it's you and what you've created with the rest of your team convincing a doctor that there's actual outcome differentiation and care for patient here that convinces them to say, I do want to take the risk on a startup versus working for the hospital I work for. I do want to take the risk of being part of a specific obesity treatment platform as opposed to, whatever I might have been doing previously, because that feels like it would be challenging. If I were the startup founder, you convincing all these providers to say, hey, let me be part of this platform in these early years, feels like it would be a challenge, but you're convincing them because at the end of the day, you're saying these things to them that they go, yeah, if I could be part of this instead of the double booked and I'm feeling like it's January and December and it's not in the middle months that I'm making impact.
We've had no issues on doctors, convincing doctors. We've had no issues on basically the people buying, right? So like, I do think the reason this is getting sort of standard is like at this point, employers and health plans will not engage with you if you do not employ your doctors because they've been through too many of the pill mills, right? The doctors are not hard to convince because like you do not need to explain to a doctor that sort of normal practice of medicine is painful and broken, right? Like this is not like, we're not like, oh man, like, is like, you may not have noticed that they're like, they've noticed, right? They're very aware. I'm going to sort of say, and this is going to have to end up getting edited, the hardest people to convince are VCs, right? Like,
actually, that was my last question. So let's go there and then we'll go to the crowd for questions. Because we've talked about convincing people generally, the stigma of it all, the patient experience, the doctors now. Let's talk about that final boss because it feels necessary for your model. It feels like you're probably, correct me if I'm wrong, you're probably going to need to continue to raise venture capital to grow and scale this thing. What has that been like?
So look, the way I sort of think about it is it's like any dating process, like there's got to be a mutual match.
Yeah.
And so like if you're not a mutual match, I actually think it's great that we figure that out early. And, early on when we were raising our seed round, like I did have VCs who were like, everyone is going to be on Ozempic. And I was like, I don't know that you understand, but like at best, this drug is going to cost $500 net. And the average cost we spend for all of healthcare on a person is $750. And so you can see that if 50% of the population goes on a drug that costs $500, that's $250. And I've now literally increased costs 33%. And that's not sustainable. And I thought this was pretty easy math to like very quickly understand. And they'd be like, it is a miracle drug and everyone's going to be on it. And I was like, this is not like, this is like, this is not going to work for both of us, right? Like there's something not, like I'm using numbers. I don't know what you're using, but this isn't going to work out for us, right? So look, I think like I try to be really respectful of everyone. So if I sort of put myself in the shoes of others, so if I
by the way, I'm surprised you said this first. Were they even, does that mean they were more aligned on the problem than I thought they might be? I guess because they see dollars, but did they also have some of the stigma and go, like, did you feel a lack of care from the venture community in terms of wanting to be part of this broadly?
Maybe. So look, I think actually to give credit to the venture community, I think many of them did recognize some of the similarity to mental health early on. But I think part of it is they didn't understand the solution. So I would say to give them a lot of credit, and this is where I will say, like, I think many in the venture community got the problem early and they got the demand early. But then I think their solution was like straight to pill mill, right? Like, how do I get GLPs in as many hands as possible? And I think, early on, I was talking about things like adherence, where I was like, look, the problem is people are not going to stay on the drug, which like I will now say I've been very, very validated on this point, not because I'm particularly brilliant, but because I come from healthcare. And in healthcare, we can't get people to stay on dialysis and insulin. And you know what happens when you get off those? You die, right? And so like, and by the way, there's like lots of reasons that happens, right? Some of them are socioeconomic, like all these things. But the reality is I think people were missing the point, which is like the be all, and I think this is a general miss in the community. The treatment is part of the solution, not the whole solution. But I would say one of the things that I find really shocking is VCs are willing to spend a lot of money, let's say, on direct-to-consumer marketing, et cetera, and that feels like a valuable investment. But a lot of times the idea of like, hey, I'm going to bring on a high-quality care team, but for 2 months, they're actually going to be underutilized. Like that feels much less comfortable. And so not for everyone, like I think this was part of our matching process of finding the types of firms who basically said like, we actually deeply believe that like you need the right model here. And here's the metrics that we want to see, right? Are you driving XYZ outcomes? Are you doing that? And I think that was a really important part of finding sort of like in the same way we have to find the right doctors, right? We have to find the right doctors. We actually have to find the right investors, right? Because to me, alignment matters so much, right? Like you want to make sure that everyone's rowing in the same direction. And that is you're rowing in the direction of what your clients want, right? Like you shouldn't promise someone something that like makes no sense, right? You can't row in that direction. You've got to have your team rowing in that direction. And you've got to have sort of the capital base that sort of believes in what you're doing and sort of is aligned with you on sort of what matters. And so I do think, part of this is in my opinion, there needs to be ongoing learning around healthcare in the financial community. So I think a lot of folks in health got excited about healthcare because they're like, man, really big market. But then they tried to take principles from tech or consumer, and it doesn't quite work that way, right? And there's wonderful things we can learn from those areas, like not faxing documents. We should really, in healthcare, we can really learn about new solutions, right? Not faxing. There's wonderful things we can learn from consumer, right? Around how do you engage people? How do you make information meaningful for them? We try to do all of that, but you also have to deeply respect, I think a lot of times, and I see this not just VCs, but founders come in and they're like, everyone in healthcare is an idiot. They're missing this point. And you're like,
or
that could be one way to approach the issue, or you could actually try to understand what are.
Well, it's interesting because you mentioned the idea. It's the stuff they did fund in the pill mills is a copy paste of there's a cost of acquisition.
Yep.
I have my marketing spend, and everything on the delivery side is a fixed, understandable cost. Whereas you're saying, look, I'm just moving some of the variable cost over to care. We can actually acquire maybe even more cheaply than you do in these other models. But here's where the variable is going to be. By the way, because we're outcomes focused, we can be assured of certain things happening here, but it doesn't copy paste in their brain as nicely.
A lot of, and again, we all operate on pattern recognition, right? I started this by saying, man, I saw pattern recognition between obesity and mental health, right? So everyone operates on pattern recognition. But I think the thing you have to constantly test is my pattern recognition appropriate in this world, right? And so I think that can sometimes be the challenge of taking pattern recognition from, a consumer acquisition market and applying it in a different market.
Totally. Elina, this has been a fantastic conversation. Round of applause for you.
Thank you for having me. Thanks everyone for coming out in the rain.